This has been going 3 years. Today's sessions will focus on highly practical cases. So with really merits careful, detailed discussions. At least for me, I'm very curious to listen to the both speakers. We have two speakers, one from Telangana, another from Andhra Pradesh. And the first speaker, Dr. Sri Pani Koplani, is a consultant nephrologist at Citizen Hospital, Hyderabad. He will present on the post-liver transplant and a secondary renal event that proved a pivotal in a challenging clinical scenario. So as far as I know, Pani is very soft-spoken, very taciturn, but when you throw a question to him, his answer will be very crisp, and his answer were consistently very incisive and illuminating. So I always admire that quality from you. And this platform is not familiar to him, and he has presented a case and also served as a panelist once, if I remember correctly. So everyone, the whole crowd knows about his all the background, everything. And the second speaker, we have Anand Rao. I think Prasili is involved in the cadaver transplant. He just called him in the afternoon and said probably might join. I thought he would withdraw, but he's making us, he's going to present a diverse cluster of cases, TMA mimics, and he will be ably supported by ma'am, pathologist, as one of the ma'am. So he would step away from this meeting, and anyway, I appreciate his commitment that he said he would come with his presentation today. So thanks, Anand Rao. And we have two very academically oriented as a panelist, one Dr. Susin Alexander ma'am from Department of Nephrology, Christian Medical College. Beyond her departmental responsibilities, I think she serves as a principal researcher with a numerous accomplishment to her credit. She's an examiner, highly sought after speaker, and he actively engages in IgA nephropathy research. And for that, he's involved in various clinical trials also. So whenever the IgA nephropathy talk comes, she's the one comes in mind for every talk. And warmly welcome her for the panelist. And second, none other than Satish Balancer, and he's on board today for the. He's erudite and very insightful nephrologist. We know from the group, he's always blend science with the philosophy. So he's an all-rounder. Any given topic, he can talk on anything. So we are having again as a second time as panelists today. So with this short introduction, and I think we will go with the first presentation, Dr. Koplani.
Thank you, Dr. Velarvind. I'm privileged to have Dr. Swarnalatha with me today. She's a titan in histopathology. I'm sure everyone knows, and she's obliged my request to be part of this presentation. Thank you, ma'am. So let me just start by sharing my screen.
Yeah, okay. Visible.
Yeah, great. Yeah. So we all know that the organs don't fail in isolation, and generally it's a axis. I mean, we know from CKM, which is cardiac, kidney, and metabolic axis and pathways, we understand how significant the inter-organ relationship is in disease causation. So today I would like to take everyone back to basics. Let's go back to LKG. By this, I mean liver, kidney, and gut axis. So let me drive this point by presenting a case and discussing the pathogenesis behind this. So the case is that of a 55-year-old gentleman. He's got a history of diabetes for the last 10 years. Not that well controlled. His HbA1c was 8, and he also complained of mild peripheral neuropathy. So the bigger problem was his alcohol abuse, because of which he has developed chronic liver disease. He was cirrhotic and with child abuse class C. He also had esophageal varices, which were banded a couple of times, recurrent gastritis, and he was fluid overloaded too. Sorry. So with that background, I mean, the hepatology team thought that he would benefit from a liver transplant. So in the pre-transplant workup, basically it showed a creatinine which was normal. He was hypoalbuminemic, probably because of the liver failure. His bilirubin, as expected, was elevated. He was slightly anemic with a HbF of 9. His viral screening was negative, his urine analysis showed trace of protein and a trace of blood. However, a 24-hour urine protein collection has shown a value of 282 milligrams in 24 hours. So he went on to have, he went on to have a liver transplant in May this year. So as per the hospital protocol, he was not given any induction therapy other than methylprednisolone. This is a deceased donor liver transplant. And he was started on tacrolimus initially and a week later mycophenolate. He had pretty good recovery and was discharged about 2 weeks later. His albumin, liver function test, and coagulopathy started to recover by the time of discharge. And on follow-up, he was noted to have intermittent episodes of neutropenia, because of which mycophenolate was stopped, and he was maintained on TAC and Vicelone. However, 3 months following this discharge, that's from about August time, he started having bilateral pedal and facial edema. So further sort of clinical examination has suggested that he was hypertensive. His creatinine has gone up from a value of 0.7 to 1.2. His CUV showed 2 plus protein, 2 plus blood. And now the protein creatinine ratio is 14 grams per gram of creatinine. And there is also a decline in his albumin to 2.5 grams per deciliter. An ultrasound showed normal sized kidneys. And given his history of diabetes, he went on to have a retinal screening. And this showed only mild bilateral non-proliferative diabetic retinopathy. At this point, he was initiated on diuretics, fluid and salt restriction, and ACE inhibition. So I would like to ask Dr. Swarnalatha to chip in because he had a kidney biopsy at this point. Ma'am.
Yeah. So thank you, Dr. Pani. So with this history, post liver transplant with nephrotic range proteinuria, nephrotic syndrome, and a raised creatinine, we received the renal biopsy. And yeah, I should ask you to change, Dr. Pani. Yeah, sorry. So this was the piece that we received, a single core, which was adequate. A top panel showing the H&E stain and the bottom the PS stain. And these balls are the sclerosed glomeruli that you can see at this very low magnification. Next slide, please. Yeah, next slide.
So this
I think you have to change, Dr. Pani. Yeah, thank you. No, can I go to the...
Hello.
Can you please mute everyone? And yeah, please, ma'am.
Some problem. Can I have the previous slide, Dr. Pani?
Yes, yeah, it got disconnected.
Oh, you've got it. The previous one?
Yes, ma'am. Yes, ma'am.
Yeah, thank you. So here you can see that many of these, there are actually almost like 6 glomeruli which are sclerosed, but there are others over here which are quite cellular. You can even at this very low mag appreciate the crescents over here. So next slide. This is a vessel which is showing prominent arteriosclerosis. The intima is markedly thickened over here. And there are areas of tubular atrophy over here, about 20 to 25% tubular atrophy. These are the cellular gloms, which I'll show you in high mag. And then the tubules show some injury, but there's no cytoplasmic vacuoles, no calcification. The striped type of fibrosis is not there. There's no arteriolar hyalinosis. So there were no features typical of a CNI toxicity. And there were no features of a diabetic nephropathy. Next slide. So these are the 5 gloms in high magnification. These are the 4 with crescents. There are 2 with cellular crescents, 2 with fibrocellular. The underlying tuft shows some mesangial widening, cellularity over there. And there's one glomerulus with at least one with a segment of sclerosis. And there was definitely some mesangial widening with cellularity. The next picture shows you the immunofluorescence, which shows the mesangial deposits of IgA with some C3c. So we have the diagnosis, next slide, of an IgA nephropathy. The pattern of injury was mesangial hypercellularity, one showing segmental sclerosis, 4 showing crescents, which were very worrisome to Dr. Pani, should he be going aggressive on the treatment. But there was also 9 out of 16 gloms which were sclerosed, 20 to 25% tubular atrophy and arteriosclerosis. So are these chronic changes attributed to IgA nephropathy, or is it a background hypertensive nephropathy? So while this is IgA nephropathy, which is a very common diagnosis, these are the points of interest in this case, that it was post-liver transplant, which is unusual but reported in literature. Is this primary or secondary? It's very hard, if not impossible, to say on the biopsy because the findings are identical. Even if you do the staining for the poorly galactosylated IgA1, it would be seen in both the conditions. If it is indeed secondary, was it present at the time of liver transplant? Not clinically, because there was no signs of liver dysfunction at that time. Did it develop after liver transplant when his liver function became normal? Something to ponder about. Are the pathogenesis different in primary and secondary IgA? Is it important? And is it important? More important, does it affect the management? So these are questions pertinent to this case, and Dr. Pani would be discussing this further. Over to you, Dr. Pani, and thank you very much for this invitation.
Thank you so much, ma'am. So essentially, I mean, we have this 55-year-old gentleman, alcoholic liver disease, underwent a liver transplant. 3 months down the line, on tacrolimus and steroids, presented with nephrotic syndrome and a progressive kidney dysfunction, and a biopsy was suggestive of crescentic IgA nephropathy. So I just thought, well, as I said, we'll go back to the basics and trying to understand what could be the pathogenesis. Is primary IgA nephropathy somehow different to the secondary IgA nephropathy? So I thought I'll just visit the basic pathogenesis of these conditions. So here we know that IgA nephropathy is somehow related to the gut mucosa, because it's not uncommon for us to see patients presenting with macroscopic hematuria, especially when they're having a sore throat or having some gastrointestinal infections, and we have associated it always with primary IgA nephropathy. And also we know that there is a molecular link where the mesangial IgA1 is mostly polymeric, and polymeric IgA1 is primarily manufactured in the gut mucosa. So if you talk about the galactose deficient IgA1 production, which is thought to be the primary pathogenic molecule in this process, whether it is pathogenic or not, we'll try and understand. So this picture, we have all seen it, and this is a picture showing the terminal ileal here. This is these are the cells lining the terminal ileum, and as you can see, there are these specialized cells called M cells. The function of the M cells is to sample the bacterial antigens that are floating in the gut and take them to the Peyer's patches. So they primarily cytose these antigens across the epithelium into the Peyer's patches. And within the Peyer's patches, these antigens are taken up by the dendritic cells, macrophages, and also by the follicular dendritic cells. And the follicular dendritic cells present these to the B cells, and with the help of CD4 T cells that were primed by the dendritic cells, they start making IgA1 molecules. And these are specifically a subset of IgA1 molecules called galactose deficient IgA1. So as they are made, they enter the lymphatics, and from within the lymphatics, they enter the lymph nodes, and then they become plasma cells. And from the plasma cells, they re-enter the lamina propria of the mucosa to secrete this IgA1 molecules. So if we drive a little bit further into this, so here you have the terminal ileal epithelium, and below that you have the Peyer's patch, and this is all the machinery, the TB and dendritic cells come together to make a B cell that produces the IgA1. However, there are certain important things to note. In a person who does not have IgA nephropathy, these B cells actually express homing molecules of CCR9 and CCR10. The ligands for this are located in the small and large intestine. So once this B cell is made, they go back to the lamina propria of the mucosa and starts protecting the mucosa. However, in patients with primary IgA nephropathy, where there may be a problem with altered microbiota, genetic factors, people with aberrant mucosal responses, infections, lead to increased production of IL-6 and TNF-alpha. So within the local mucosa, there is excess production of IL-6 and TNF-alpha, which actually leads further to the production of APRIL and BAFF. And APRIL and BAFF, we know, help to mature the B cells into plasma cells. And also they regress the expression of CCR9 and CCR10, which are the homing molecules for the mucosal epithelium. And as such, they also express CXCR4, which is actually a homing molecule for the bone marrow. So in the context of abnormal sort of microbiota dysbiosis or genetic factors, there is excess production of IL-6 and TNF-alpha, which leads to excess production of APRIL and BAFF. That leads to the homing mechanism of these B cells to be altered, and then they get seeded within the bone marrow. And we all know about this 4-hit theory, where the increased circulating galactose-deficient IgA1 should not be present in excess quantities in the bloodstream, but in patients with IgA nephropathy, this is found in excess. And then there is a second hit whereby these galactose-deficient IgA1 molecules are identified as foreign, and the immune system produces antibodies against them, and they form a complex in hit 3. And when they get deposited in the kidney, leading to mesangial inflammation, and glomerular injury, that leads to primary IgA nephropathy. But there are a few other important things that I would like to discuss. So what is actually about this aberrant IgA glycosylation? Why does it happen, and what is the importance of it? So if you look at the mucosa, and the mucosa is obviously trying to protect us from these exogenous antigens, primarily derived from pathogens. These are called PAMPs, or pathogen-associated molecular patterns. And they could be in the form of something called CpG DNA, which is the DNA of the bacteria, which is usually unmethylated. In humans, it is methylated. So that's how the system differentiates between these two. And once this CpG DNA is identified by the toll-like receptors, which are the receptors that identify these dangerous signals, they lead to activation of NFK beta and lead to production of IgA. And in the presence of IL-6 and TLR9 activation, there is excess production of IL-6 APRIL, and that leads to this aberrant glycosylation of IgA. But in the first place, why is this even needed? So if you look at this IgA, it's per se is not pathological. I mean, we all have galactose-deficient IgA1. So this is the Y-shaped IgA molecule. And you can see the hinge region is sort of rich for serine and threonine molecules. And these sort of bind the glycans. So this is called O-glycans. So typically, the serine and threonine will be attached to this particular molecule called GalNAc, and to which the galactose is attached, and to the galactose there is a sialic acid that is attached. So this is actually a normal IgA1. In the context of mucosal produced IgA1, this is absent. So the galactose is absent. So the GalNAc is directly attached to the sialic acid. So this is what we call as galactose deficient IgA1. And as such, this becomes what you call as an antigen that the body has not been exposed to, and in excess of it, the body produces these galactose deficient IgA1 specific IgA. So, but why do we even need this? Because it's thought to be part of the normal mucosal immunity, and they can be produced pretty rapidly. That's one of the reasons why the mucosa produces them, especially during acute antigen exposure. So it's trying to churn out these molecules as quickly as we can. And they also have certain characteristics which help the microbial binding better. So when there is less galactose, the hinge region is more flexible, which means more bacterial antigens could be targeted by this. And usually they're short-lived and are efficiently cleared by the liver. So galactose deficient IgA1 is not abnormal per se, but when it is produced in excess, that's when it becomes abnormal. So the next question is, what actually determines the galactose deficient IgA1 clearance? So this is a schema of a liver where you can see this hepatic sinusoid, space of Dicey, and hepatocytes. The hepatocytes carry a particular receptor called sialoglycoprotein receptors. So the purpose of this is to identify any galactose deficient or any IgA1 molecule that has lost its sialic acid. So when an antibody becomes old, it loses its sialic acid. When the sialic acid is lost, it attaches to the galactose and it's sort of taken into the hepatocytes where it's taken up into the lysosome for catabolization. So in galactose deficient IgA1, if it is in excess, because there is less of galactose, these receptors are not able to sort of catabolize them, which means they are likely to remain in the circulation for longer. Likewise, when the galactose deficient IgA1 binds to the autoantibody, they become too big to go through this endothelial fenestration. Thereby, they get trapped and are not catabolized. So, in essence, this IgA1 disease manifestation is actually influenced by overproduction of polymeric galactose deficient IgA and also impaired galactose deficient IgA clearance mechanisms, leading to deposition within the kidney. So, what is it to do with IgA nephropathy and chronic liver disease? We always have known that patients with chronic liver disease are more prone to developing IgA nephropathy along with certain other conditions like mesangial proliferative GN. So, especially, I mean, this is supported by a lot of epidemiological data where in one study, almost 9 to 25% of the liver transplant candidates who were being sort of assessed for liver transplantation, they were found to have IgA nephropathy. So almost 25% of the patients with some kidney dysfunction may have IgA nephropathy. And similarly, if you look at the proportion of patients that were diagnosed with IgA nephropathy, almost 9% of them may have cirrhosis. It's most commonly associated with alcohol liver disease, also known to be seen in the context of hepatitis B and C viruses and non-alcoholic steatohepatitis. So if they have a proliferative lesion, as we know, we may see hematuria and proteinuria, and sometimes they're non-proliferative lesions and they may have just minimal abnormalities. So what really happens in cirrhosis? So if we come to this, in cirrhosis, because of altered echo texture, there is increased portal pressures leading to portal hypertension. And because of which the gut mucosa is congested. When the gut mucosa is congested, there is breakdown in the barriers, mucosal barrier, leading to bacterial translocation. And once the bacteria enters the systemic circulation or into the Peyer's patches, by virtue of toll-like receptors, this lipopolysaccharides and CpG DNA get sampled by the toll-like receptors, leading to activation of the B cells. And the B cells, in the context of IL-6, TNF-alpha, BAFF, APRIL, they start producing a lot of galactose-deficient IgA1. And as such, we also know galactose-deficient IgA1 itself can stimulate the plasma cells, leading to a positive feedback loop. And once these are produced in excess, then they go to the liver. But there are two important mechanisms that make the clearance more difficult. One is the portosystemic shunting, because when the in the context of portal hypertension, the blood is diverted away from the liver. So the access for these galactose deficient IgA1 to even reach liver is reduced. Likewise, even when they reach, because of the scarring that is going on, the endothelial fenestrations become quite narrow. Thereby, there is a mechanical barrier for these galactose deficient IgA1 to reach the hepatocytes for catabolism. And also, it was known that there is reduced receptor of asialoglycoprotein, which we have talked before. Another issue that typically found is patients with cirrhosis also suffer from galactosyl transferase deficiency, which means for the IgA1 molecule to be galactose, for it to have a galactose molecule, there is a particular enzyme, and that enzyme is also deficient in the context of liver disease. So there are multiple different reasons why IgA nephropathy may be associated significantly in the context of cirrhosis. So this is literally what I just gone through. So in the primary IgN, there is abnormal O-glycosylation, primarily of the polymeric IgA1. This is primarily of the mucosa. However, in cirrhosis, it can be both monomeric and polymeric. And then they can lead to deposition and activation of the immune system within the glomerulus. So there is yet another connection, the gut connection between IgA nephropathy and inflammatory bowel disease, where we know there is excess cytokine milieu in the context of Crohn's and ulcerative colitis. They do share some genetic risk, IgA nephropathy and inflammatory bowel disease, both relating to one, mucosal immune system, and two, in relation to toll-like receptor ligands and heightened sensitivity, and three, also this galactosyl transferase enzyme may be mutated in these patients. And we also know that there is a good treatment response once this inflammatory bowel disease is treated with anti-cytokines or anti-TNFs. The mesangial IgA depositions have been documented to regress. So looking at what really happens, I mean, are we expecting that IgA nephropathy to just completely disappear after liver transplant? This particular study says otherwise. This is a small study where from a single tertiary center, 14 patients with IgA nephropathy and end-stage liver disease, they all underwent liver transplant or combined liver, kidney, and transplant. Here, patients that had liver transplant only, the hematuria persisted in 2. There is progressive loss of kidney function in 4, worsening of proteinuria in 3, and 1 progressed to end stage at 5 years. So if you look at it, none of them actually had any regression in their underlying kidney disease. And then in the context of a combined liver kidney transplant, it's a slightly better, but still there is a chance of histological recurrence and histological and clinical recurrence in 2 out of the 5 patients. So IgA nephropathy may not actually necessarily get better after liver transplantation. So final thoughts on this. Post-transplant IgA nephropathy is complex. Multiple mechanisms may be involved. They could be having a pre-existing IgA nephropathy, which has not been manifested before transplantation. So there are a couple of possibilities here. Post-transplant changes may unmask this pre-existing disease by virtue of better hemodynamics. Whether that's just a thought, I'm not sure if that is completely relevant. Again, there is this gut-driven IgA production, which may not actually stop after a liver transplant. And then the more important and most fascinating thing I find is this bone marrow plasma cell seeding. So once this process has begun and the B cells or the plasma cells go and seed in the bone marrow, liver transplant or no liver transplant, this process is going to continue. And then there is incomplete restoration of IgA clearance, even though the new liver should be able to process these IgA molecules. Still, the presence of polymeric IgA with an autoantibody can make the clearance difficult because of the size issues, as we discussed earlier. And then galactose-deficient IgA1 alone is weakly pathogenic, as we discussed, but this in the context of autoantibody, I mean, we are not addressing the autoantibody at all by doing a liver transplant, and hence it may still be important. And post-transplant modifiers, because in our particular patient, at the time of transplant, he had proteinuria of 282 milligrams. I mean, it's not nothing, but his hemodynamics may have prevented that to become a overt disease. And subsequently post-transplant, because of better hemodynamics, we may have seen worsening of the proteinuria. That's one thought. So with that, I just want to conclude and thank you, and open to questions and more questions that I have for the moderators to answer. So at this point, I'll just hold as to what actually I did. I mean, this is early, only in the last week or so we got this diagnosis. And then I would like to ask everyone about their thoughts on this particular case.
Thanks, Mani. Thanks. Very interesting, and you covered extensively. And now we'll go to the panelists. And then there are a lot of questions in creeping up in mind, and because, ma'am, Satish Balan sir.
Yeah, I think you should ask Sina first, no? But anyway, in this case, you know, my personal.
Can you unshare, Pani? Can I, so that we can see this panelist face, right? Can you unshare that?
Yeah. Yeah.
What is the treatment plan you are adopted? Let's.
Yeah, I said I'll ask you questions.
It's a very tricky thing. Okay.
Hi, Dr. Pani. Few questions, just a few clarifications. One is, why didn't we consider renal biopsy pre-transplant?
It's a good question. I was not involved at the time, so I don't know what exactly, because his creatinine was normal. His proteinuria was 282 milligrams in 24 hours.
So it was more like a non-diabetic kidney disease, right, at that point?
So absolutely. I think possibly also the history of 10 years, and he's got mild NPDR.
Yeah.
I guess those were the reasons why a biopsy was not considered. And again, all these patients, as you know, are coagulopathic, and doing a biopsy in such patients is definitely not trivial. So I think those would be the considerations, I guess.
Okay. And were there any history of skin lesions?
Was there any history of skin lesions? I don't know the specific intent, but I don't recall him having any skin lesions.
Okay.
And
The other
there is a
interesting
question.
thing was about in the histology, there was a lot of sclerosis, glomerulosclerosis.
60%.
It could be pre-existing,
Correct.
which if we had a previous biopsy to go with, then we could have correlated. And he has post liver transplant, he developed heavy proteinuria with hypoalbuminemia, which is not really in keeping with just an IgA nephropathy. Maybe explainable by the sclerosed glomeruli, but
So
an
I think
EM at this point may throw some more light.
I'll just see if Dr. Swarnalatha could answer some of the questions.
Yeah, the EM. Did you talk about EM?
Yeah,
No.
EM, ma'am.
Yeah, EM, no. We did not do an EM on this case. But you're right. There was this population of sclerosed glomeruli, and then there were the others which were heavily, which were either had crescents or mesangial proliferation, which were very proliferative. That was quite distinct. And as far as proteinuria, I think most of the studies have shown, at least from India, including our own series, that IgA nephropathy, we do tend to see much more proteinuria than what is
Yeah,
described.
but not to the extent of 2.5 serum albumin, unless the liver is also not functioning
Not functioning
at that
too well.
point.
Yeah.
So if the liver was functioning well at that point, to have hypoalbuminemia of 2.5 in an IgA
Okay.
per se
Okay.
is a little
Right.
uncommon. Yeah.
Right. Yeah.
Yeah, so I would also go by probably there was a pre-existing IgA and
Certainly. I think the CUV at the time of transplantation showed definitely a trace of protein and a trace of blood.
blood, yeah.
And, as I said,
And the fact that it was an ethanol-induced
correct.
CLD.
Correct. I mean, we completely take your point that there is, we were discussing me and Dr. Swarnalatha to say that he has got a lot of glomerular sclerosis as to what we would normally expect, and whether there is a chronic underlying process that we haven't picked up the origin for the first time. But what is surprising was his albuminuria, his proteinuria at the time of transplantation with that amount of glomerular sclerosis was still pretty minimal. And that argues against the possibility that this is just purely global sclerosis related. As you rightly said, whether we will discuss whether we should probably consider this electron microscopy as well. That's a very fair point.
Well, just one thing, Susina, you are muted.
The other thing was about the creatinine per se. You said creatinine is 1.2, but so much of sclerosed glomeruli. Is that really the reflection of the GFR in a post-liver transplant setting? And would you want to use a statin C as a better marker?
Yeah, I think that's absolutely right. I mean, now the creatinine is around 2. I mean, obviously, he has been malnourished for quite some time, and his muscle mass is not great. So certainly, a statin C may be a better marker. Agreed.
There were 2 cores which you showed, and one of the cores was looking better than the other one. The other one looked more sclerosed than the other, isn't it?
No, it's the same core, one on HMB and one on PS. The other thing I, as a pathologist, keep wondering is, we see only 16 out of 1 million glomeruli, and we are trying to extrapolate. It's possible that we've got an area which is slightly scarred, and so you're getting more sclerosed glomeruli. So really not to read too much into, the numbers is my own take on. renal biopsies in general. You know?
Which we had this transplant that showed 50% glomerular sclerosis just before, and they took for dual transplant, and initially thought, but ended up with one kidney, and his creatinine has come down to 1.2. It was just like 50% glomerular sclerosis and a creatinine of 1.2. They don't match.
Yeah.
Yeah. Now, if you look at the time point also, it is creatinine normal at the time of transplant. Even though there may be some cirrhosis-induced abnormal renal function may have been there, but still this is progressing too fast after the transplant. Proteinuria progression is, and he's developing a nephrotic syndrome. So probably I think we should treat this like a nephrotic syndrome. And EM would have been ideal because we would have seen whether there's some podocyte effacement and all that. So
Did we do an ANCA levels at any point?
On this guy, yes, ma'am, they were negative.
Okay.
They were negative. But ANCA should be post-immune rather than show IgA.
Yeah. No, but the IgA staining could have been the pre-existing IgA staining.
But there is also C3C as well. So that makes it slightly unusual, I guess.
Yeah, a little difficult to distinguish.
Correct.
And then Dr. Sachin is raising
his hand. Sachin, you want to say something?
I just, this patient must be on immunosuppression. I missed the initial slides. So does this tell us that immunosuppressions were not enough to prevent the proliferative? Like you may get IgA, but like as Madam showed, it is a proliferative glomerulonephritis. In proliferative glomerulonephritis, we treat them with immunosuppression. Patient is already on immunosuppression, has developed proliferative GM. So I think it will be difficult to design a treatment strategy too.
So I think, sorry, if I can answer, it's the immunosuppression that he's on is tacrolimus and steroid, as low dose of steroid. And whether tacrolimus, I mean, there are two components here. One is the excess production of IgA1, which is unlikely to be addressed by whatever immunosuppression we give, unless it is a huge dose of steroids or cyclophosphamide or on those lines, which is likely to address the plasma cells. And the inflammation within the glomerulus should be treated by slightly high dose steroids. So even if we give the high dose steroids, which is what I'm doing at this point, my belief is it's not going to hold the process under control, because steroids are only going to just address the inflammation within the glomerulus, but it's not going to do anything to the pathogenic process. And here, I think, I mean, obviously these are not available, and APRIL and BAFF inhibitors may actually be the right choice because that's going to reduce the production of IgA1 from the plasma cells, which I think may have seeded the bone marrow at this point, rather than this is currently being driven by the gut mucosa, and from there it is being sort of pumped into the bloodstream. I don't know what your thoughts are, Dr. Satish and Dr. Saxena, on this.
No, I think what you're saying is quite right. What was the serum complement level?
The complements, I don't think we did them. No, I didn't do them. Sorry. Yeah.
Okay, because if the serum complements are also low because you have C3C deposits, there might be a role for complement.
Yeah. So I mean, conventionally, we don't always see drop in the complements, right, man? With this in the serum, at least, especially even in LHS, which is a C3 complement mediated disease.
Yeah.
So I mean, if it is low, it may help.
Yeah. No, but coexistence of C3C in the histology may be an indication for complement inhibitors also. For the complement inhibitors.
Iptacopan, yeah.
Just I have an additional view on this one. In fact, that this patient has a nephrotic syndrome, which is not a usual thing with IgA nephropathy. You can have proteinuria, but nephrotic syndrome is general. So think of a primary podocytopathy. In that case, your steroid will be a good choice of drug. Then probably he might respond. So there have been patients we have seen, I think all of us would have seen patients with IgA nephropathy and the podocytopathy, and we use steroids, completely disappears everything.
So like a minimal change, or
like a minimal change. IgA deposits are incidental,
but it's got so much of proliferation.
Only thing is that you have those crescents. I don't know. They may have been there earlier. We don't know.
They all look pretty active with similar crescents, I guess.
Okay, sir.
The other thing is you told us that you have stopped MMF. what was the interval of the symptom after, how long after stopping MMF did he develop the nephrotic syndrome?
I think right initially, I mean, I started seeing him from something like September, and he was stopped within 2 months after the transplant. The mycophenolate was stopped because he was happily having some cytopenias.
And was this nephrotic syndrome immediately after the stopping, or?
I don't think I can clearly pinpoint that, but I can go back and check the notes.
Okay, because MMF, again, it's a B cell inhibitor, though not like as specific as BAFF and APRIL, but
Yeah.
still a B cell inhibitor, and probably whether the withdrawal of the drug led to an acceleration
Acceleration of the process.
process.
Okay. So I think we have 20 minutes for the next talk to proceed. Thanks, Mani. Be there when any questions pops up, then that you will be here to answer for the thing. And it's very interesting. Actually, the discussion will go on for another 1 hour because it's such a enigmatic disease, and still we don't know the answer. The whole world is evolving around this disease, and still we are desperate in finding a solution.
Just a final comment, Will. So I think at this point in time, we should think about giving steroids and giving mycophenolate, isn't it? So maybe a good choice. And then we'll take it from there.
Thank you.
There is one question in the chat box. Do you, take
why
data?
there is why it is only IgA, not IgG and IgE on, and then another is a chaperone like enzyme therapy. I think you addressed IL-6 and BAFF and APRIL target may be the best one. That's the second is answered. The first one, Pani has to answer.
The first one, the hinge region is there only in the IgA molecule, and the only other immunoglobulin molecule that has hinge region is IgD, which is actually a membrane-bound immunoglobulin.
Okay.
So the O glycoxylation is there only in IgA.
Okay, fine. Answered.
Thank you.
Okay, we move on to next. Anand?
Yes, sir.
Yeah, please make your presentation. Take extra 5 minutes. Don't worry about, don't rush, and take your time, and just share your slides.
Is my screen visible, sir?
Yeah, absolutely fine.
Sir, at the outset, I would thank Dr. Rajarajan and Dr. Velarvin sir for giving me this opportunity. I'll be presenting 3 cases which I have seen, and the lessons I have learned from them. Briefly, I will be going through these cases. Case 1, he's a 32-year-old male with a history of ulcerative colitis. He
You
was
can't
on.
see your presentation.
Do you have slides, Anand? There is no slide visible here.
Okay.
Can you share your slides right now? Okay.
Is it?
Yeah, fine,
Is
fine.
Yeah, put it in the presentation mode.
Yeah, play mode and just to start. Yeah, thanks.
Yeah,
Okay.
fine.
Fine.
Sir, a 32-year-old male with history of ulcerative colitis. He was on steroids and azathioprine for 3 years. He presented with pedal edema and vomiting, and his evaluation revealed serum creatinine increased from a baseline of 2.5 to 7 within 15 days, and with active urinary sediments. The diagnosis was RPRF. So the biopsy was done as the diagnosis was RPRF, and it showed TMA. Genetic testing was negative, and his anti-factor H antibodies were positive. So he was treated with plasma exchange and steroid. He achieved hematological remission. After stopping plasma exchange, his renal dysfunction worsened, and he was restarted on dialysis. He was declared ESRD and kept on peritoneal dialysis. After 3 months of PD, he proposed his mother as a donor for renal transplant, and subsequently transplant was done. On day 8 of post-transplant period, his graft dysfunction started, and a graft biopsy done at that time showed TMA, and subsequently he developed a graft intolerance, and he did not respond to plasma exchange, immunosuppression, steroids, and he needed a graft nephrectomy at that time, and he was continued on PD. So later, after a week, his native kidney urine output improved, and his serum creatinine settled at 4 mg per deciliter, and dialysis was stopped. So what I thought from this case was in anti-factor H antibody related TMA, like we see in anti-GBM or other immune complex mediated diseases, it is better to wait for longer period on dialysis, at least 6 months on dialysis before going for transplant, and adequate immunosuppression to be tried in these cases before jumping for transplant. Case 2, he was a 24-year-old male who presented with headache. When evaluation was done, his blood pressure was 200 by 100 millimeters of mercury and serum creatinine was 2.2 with active urinary sediments. His kidney biopsy showed 14 glomeruli, out of which 1 was sclerosed and only 5% IFTA during the first biopsy. And vessels showed features of hypertension, fibrin thrombi were present. To start with, the diagnosis was not primary TMA here. The vessel changes were attributed to hypertension-related thrombotic microangiopathy. And his immunofluorescence showed 8 glomeruli, 2 sclerosed with IgA, IgM, and C3c deposits. He was managed only with antihypertensives, but he lost follow-up. Subsequently, after 3 years, he presented with pedal edema, and his serum creatinine has increased to 4 mg per deciliter by this time. His BP was still 200. Repeat biopsy showed 6 glomeruli with mesangial expansion and hypercellularity. 2 glomeruli showed segmental sclerosis, and IFTA was 25% by this time. And immunofluorescence showed 5 glomeruli, out of which 2 were sclerosed, and there were mesangial deposition of IgG, IgM, C3c, peripheral C1q, and minimal mesangial IgA. So with significant C1q deposits, the biopsy diagnosis was lupus nephritis. Again, he lost follow-up and was not compliant to treatment. After a year in 2022, he presented with breathlessness and his serum creatinine went up to 9 mg per deciliter by this time. He reached ESRD now. He was initiated on dialysis and fistula was created. Despite 5 antihypertensives, his BP was persistently above 170-180 mmHg. In October 2022, he proposed his father as a donor for transplant for ABO compatible haplomatch transplant with CDC crossmatch negative. In January 2023, transplant was done. His post-transplant creatinine was 1.2 mg per deciliter and BP was still 180 by 100 on 4 antihypertensives. During follow-up, his serum creatinine started to rise and a biopsy was suggested, but the patient was not willing for the biopsy. The evaluation for graft dysfunction was grossly normal. Doppler was normal. TAC levels were within the range. Hemoglobin and platelets were normal. There was no evidence of systemic TMA during evaluation. In the second month, his creatinine was 1.8. Third month, it increased to 2.2. Fourth month, it went to 2.8. And finally, in the 5th month, he was convinced to get a biopsy done, but it was too late by that time. So renal biopsy showed thrombotic microangiopathy with 6 glomeruli and 2 were sclerosed. There was no evidence of rejection in this biopsy. Glomerular basement membrane was thickened and double countering was present in 50% of the viable glomeruli, which indicates already chronicity has set in. And tubule showed severe tubular injury and features of chronicity were present. And IFTA was around 15 to 20%. Vessels showed features of hypertension. C4D was negative. And hyperplastic arteriosclerosis and intimal myxoid change were present. So for benefit of doubt, although double contouring was present, we started him on plasma exchange and 5 sessions of plasma exchange were done. Initially, creatinine sort of stabilized at 3 milligram per deciliter, but subsequently the graft function started worsening. And in the 7th month, that is in the 3rd month of therapy, the graft loss was declared and he was put back on dialysis. Subsequent evaluation during that period, anti-factor antibodies were negative. Genetic testing did not show any complement abnormality. TAC levels have always been within the range, and donor-specific antibodies were negative, and workup for infections like CMV, BKV, they were also negative. Despite extensive evaluation, we could not identify what caused TMA in this patient. So from this patient, what I concluded was severe uncontrolled hypertension with vessel changes of hypertension may be a presentation of primary TMA. Initially, we thought hypertension has caused TMA in this patient, but looks like the other way around. So, extensive pre-transplant evaluation for cause of TMA and high index of suspicion in post-transplant graft dysfunction and early biopsy are very essential in such patients. Especially, we see a lot of patients who present with severe hypertension and without any underlying cause, but the biopsy may not be contributory, like IgA or other disease may not be identified in such cases. So what I conclude is the electron microscopy may be useful in such cases where even a biopsy does not identify a primary kidney disease. In such cases, the TMA changes can be picked up on the electron microscopy. So coming to case 3, he is a 46-year-old male with CKD secondary to diabetic kidney disease. He was on maintenance hemodialysis for 1 year prior to coming to us for transplant. He was diabetic for 14 years and hypertensive for 2 years. He also had diabetic retinopathy with treatment done for proliferative diabetic retinopathy. His sister donated the kidney, and pre-transplant evaluation showed bilateral single renal arteries and single veins. On the right side, there were 2 renal arteries, but on the left side, there was a single vessels. So DTPA of the donor showed 85 ml with right kidney 47 and left kidney 38. There was haplo match, and the CDC cross match was negative. So it was a simple low risk patient with the sister donor. Induction was done with basiliximab and maintenance immunosuppression of TAC, MMF and prednisolone was planned. So left donor nephrectomy was done. To our surprise, intraoperatively, there was an accessory artery to the lower pole. It was very small in caliber, and it was separately anastomosed to the external iliac artery end to side. Main renal artery was anastomosed end to end with the internal iliac artery. The warm ischemia time was 7 minutes, cold ischemia time was 80 minutes for the upper and middle poles, whereas 120 minutes for the lower pole because the anastomosis took a longer time. The total blood loss was around 300 ml. Immediate post-transplant, the HB dropped to 6.7 gram per deciliter and platelets decreased to 80,000 per cubic millimeter. So 1 unit of PRBC was transfused on the day of surgery. However, despite drop in hemoglobin and platelets, his urine output was well maintained and serum creatinine was decreasing. There was no graft dysfunction. He had other issues like paralytic ileus and X-ray showed gaseous distension of the bowel loops, and which was managed with conservative management and nasogastric decompression. There was no evidence of any ongoing external bleed. The drain was not much. There was no bleeding from other sides, but the hemoglobin and platelets were dropping, which was consistent with the diagnosis of TMA. However, the graft function was stable. Despite all this happening, the urine output was good, creatinine was coming down. There was no issue with the graft function. So his TAC levels were within range. Urine output was 6 liters and creatinine decreased to 2.6 on day 1 and 1.6 on day 2. So the cause for drop in hemoglobin and platelets and increase in LDH was attributed to the lower pole artery thrombosis with infraction of the lower pole. And the abnormalities improved with conservative management. Although it looked like a TMA, the cause for this hematological abnormalities was a lower polar infraction rather than TMA per se. So to conclude from this case, the post-transplant drop in hemoglobin and platelets along with elevated LDH has a wide differential diagnosis. And surgical causes like segmental renal infarction also should be thought. It is rare, but it should be kept in mind while managing such cases, and Doppler is an essential and important investigation during management of these patients. The main reason why we didn't jump onto didn't do the plasma exchange was the graft function was stable. Coming to review of TMA, the incidence is widely variable based on the study, 0.8 to 14%. There are mainly two presentations of post-transplant TMA, localized and systemic. And based on the this one, we have two classifications: recurrent TMA and de novo TMA. De novo TMA is more common in the post-transplant period. It may be related to ischemia reperfusion or drugs or rejection or infections. Whereas recurrent TMA is mainly complement mediated. So final common pathway is endothelial damage, platelet aggregation, and thrombosis. Refractory hypertension in early post-transplant period, the TMA has to be kept in mind. Other factors like drop in platelets for more than 25% or elevation of LDH more than twofold, or increase in the creatinine by 25% or proteinuria more than 300 mg per day. These are all supportive evidence. On the biopsy, what we can find is endothelial swelling or denudation and intraluminal fibrin thrombi, subendothelial expansion, and mesangiolisis and capillary microaneurysms. Once it becomes chronic, we can see MPGN-like changes with double contouring and onion skinning of the arterioles. So first step in the management is we should stop or decrease the CNI dose. If there is a rejection, then plasma exchange IVIG and rituximab. And if CMV or BKV are present, the management of those infections will decrease the TMA, ongoing TMA. Then coming to specific therapy, if it is complement mediated, eculizumab, TTP, plasma exchange. In severe cases or chronic cases, only supportive care and dialysis. So the offending agent has to be stopped. That is the most important thing. In the post-transplant, if it is a high CNI level, decreasing the CNI dose, treating the rejection, treating the infection. If it is a complement mediated, again, eculizumab, plasma exchange, IVIG. How to prevent? The de novo TMAs are very difficult, whereas recurrent TMA can be identified in the pre-transplant period, and therapies can be done to decrease the TMA incidence in the transplant kidney, especially prophylactic eculizumab, or if it is complement mediated, then in Indian setting, maybe plasma exchange, IVIG and rituximab may be useful in complement mediated TMA. Prognosis, it is highly variable, depends on the etiology and timing. Most important is picking it up early in the post-transplant period, because once 3 or 4 months pass, it becomes chronic and will not be responsive to therapy. Drug-induced TMA has very good prognosis compared to other forms. Anti-ABMR-related TMA also responds well if picked up early, and plasma exchange is initiated at the earliest. Whereas complement-mediated TMA, the prognosis is not very good, and graft loss can happen in up to 50 to 80% of cases, depending on the underlying complement abnormality. So most important prognostic factor, apart from the primary disease, is early recognition of TMA in the post-transplant period. Delay in diagnosis leads to chronicity, that leads to treatment failure and ultimately graft loss. What are the complement abnormalities that have high recurrence risk and high graft loss risk? They are complement factor H mutations, complement factor B mutation, whereas low risk are MCP mutation, which are membrane-bound protein abnormalities. The recurrence and graft loss risk are very less compared to the other mutations. So this is my last slide. The study done in AIIMS, New Delhi, where they have transplanted 4 children with anti-factor H antibody mediated thrombotic microangiopathy. What they have done is they have monitored the AFH anti-factor H antibody levels in the pre-transplant period, and to decrease those levels, they have used rituximab, plasma exchange, IVIG, and in few cases in the post-transplant period also these therapies were instituted, and post-transplant monitoring of the antibody levels were done. they have a cutoff of more than 150 AU per ml as a positive antibody level. And in all these 4 cases, they have followed up for 2 years, and a stable graft function was present. So this is the one of the studies where, despite presence of anti-factor antibodies, successful transplant was done with good outcomes, provided the antibody levels were maintained at a lower level using the one of these therapies. Where despite even if eculizumab is not present, the use of plasma exchange, IVIG and rituximab help to maintain stable graft function in these cases.
Okay.
Thank you.
Thanks, Anand. So you are covered beautifully, but the last case was interesting, and this case was discussed by 2 presenters in the same forum, I think 1 year ago. It's eye opener for many, actually. You said instantly you found. Please unshare this slides. So if you incidentally find something on the polar artery, aberrant polar artery, or accessory hilar, if you inadvertently do, without plan, you do anastomosis and later infarction. So the raising LDH is one of the signs that when you go back to do some CT scan or contrast ultrasound, then you may find it. It's very interesting. So the 2 mimics, I think the first case, I don't think it's a mimic, and I'll let the panelists discuss about it.
Yeah, just one thing. What genetic test did you do for these patients? Was it a whole exome sequence or?
Yes, sir. Whole exome sequencing to look for a complement abnormalities, sir.
Did you look for copy number variants during MLP or something like that? No. Didn't do
No,
that.
sir.
So in the
No,
first case, what was the anti-CFH antibody at the time of transplant? Was it?
Sir, the pre-transplant, the levels were low, sir.
They were low.
Below 150, sir.
Okay. Because usually how long had the patient been on treatment for this before transplant?
Around 3 to 4 months, sir. The plasma exchange, steroid, they were continued, sir. But post stopping plasma exchange, again, the serum creatinine started increasing despite oral steroids, sir.
Yeah, I think that steroid by itself is not that effective in anti-CFH antibody. So usually we give mycophenolate or rituximab. Both of these are effective in anti-CFH antibody-mediated disease.
Yes.
So, and they will reduce the antibody levels significantly. So
yes, sir.
that is one of the things we have to do before transplant in these patients. But generally, they can be transplanted safely. So the only thing is that after transplant, if there is a recurrence, you can give eculizumab because the end pathology is all complement mediated. So if you give eculizumab, you can take care of that at the end. Now that eculizumab is available, it should probably be one of our strategies when you have this type of patients. Probably we can use it when after the transplant. But anyway, with the low antibody level, maybe it was because after transplant, suddenly the antibodies might have come back. So we need to use something which prevents that. I think rituximab would have been the best. You see that AIM study, they have gone for rituximab in all these patients. And that is probably a better way to approach these patients. Now, the interesting is the second patient that you had 3 biopsies with different findings. No? The first one showed a TMA. The second one showed multiple. I don't know whether C1q alone says it's a lupus nephritis. Very unlikely because as a boy with lupus and must be if it is a lupus, should have been a class 4 lupus without any evidence of other lupus is very unusual. Membranous can present like that too in females, but not in males. So I think it is more like an immune complex mediated MPGN or IC-MPGN or something like that is more likely than anything else. And there is a lot of overlap between IC-MPGN, C3GN, and complement-mediated disorders. See, there are patients who have C3GN and they develop AHUS after transplant. So that can happen. There's some shift in the phenotype of the disease, which can happen. Now, this patient also, post-transplant, it was a slowly progressive rise in creatinine. I'm not really convinced that it's a primary TMA, not an AMR-related TMA. I know you said C4D was negative, no?
Yes, sir. C4D, DSA, both were negative,
C4D, DSA, both negative. So that makes it very less likely. But still, there are other mechanisms now. C4D is complement-mediated, can be ADCC-mediated, and non-HLA antibodies. So rare things can happen. So that is also possible because the time period of progression is very slow. No? Usually a TMA, recurrence of TMA, you would expect a more explosive course. Not that it cannot happen, but it looks something like this. So probably plasma exchange might have helped in this patient also. I don't know how, but still.
We did the plasma exchange, sir, but by the time
I
it was
think
already
by the time it was already
EG
gone.
was
No?
present.
Yeah,
Yes, sir.
yeah,
Yes,
it was too late. Nothing much we can do at that time.
yes. To start with, the suspicion of TMA was not there, sir.
Yeah.
Because the primary disease was more like a immune complex or IgA. That sort of a working
Yeah, I agree,
diagnosis
but
was there.
yeah. The thing is that by the time you had TMA, you also had the double contours, you had the mesangial,
Yes.
membranopolluted type of appearance. So that also fits in. So what about PTC? Was there any PTC?
No, sir. There was no evidence of any glomerulitis or peritubular capillaritis.
Okay. So how do we know it's not a recurrence of a glomerulopathy? No, that's also possible. So primary glomerulopathy recurrence. Again, there's no IF findings were not there, no, in this patient.
Yes, sir. Yes.
No IG, IgG,
IF,
nothing
no,
was
sir.
there.
Yes.
It's probably pure TMA. But one of the causes of TMA is antibody-mediated rejection also. Can't be sure.
Yes, sir. But other features of ABMR were not there, sir.
They're not there. I agree, absolutely. So one of the things is genetics also, we should be more, I mean, of course, genetics is a growing specialty. So we should be doing copy number variants also, because especially CFHR abnormalities, you can pick up only on a CNV analysis. The main things you can pick up, but many of the so-called CFHR, everything comes as VUS. So you have to do an extensive study, whether that's actually VUS, look at the data, see whether it can be converted into a, whether you can think of it as pathogenic and find out the literature on that. So it is not easy. The genetics of TMA is still coming up. Sina, you have anything to say about that?
No, I think you've discussed all points necessary, but I would also like to emphasize that any patient going for renal transplant, especially, may be better to have a comprehensive genetic testing, especially some mutations like CFH and CFI. Just a kidney transplant may not suffice, and then you might end up with more problem in your head post-transplant. So better to rule out at least the pathogenic mutations in these genes before you take them up for transplant.
Okay, great,
That's an important point. And one more cautionary tale about combined liver kidney. That's another point which it's not absolutely safe. There are, I mean, if you look at the handful of cases in the literature, some of them have failed for no reason. Some of them succeeded. And we also had a bad experience. So
a lot of morbidity.
A lot of morbidity, and liver doesn't pick up for some reason. There's absolutely nice liver. There's no Doppler and everything is beautiful, but liver is not working. Why it's not working, we had no idea. And patient finally succumbed to a primary graft non-function of the liver. So the second patient, the first patient that we did, that we reported, that was an isolated liver transplant for a patient with complement-mediated TMA. So we just did liver transplant as a cure. She had a kidney completely normal, the TMA completely subsided. But over a period of 1 year, she developed recurrent problems with the liver and finally died because of liver failure. They didn't have enough money to go for a second transplant.
Okay.
So,
sir, like the second patient where we did not find any cause for TMA, how do we explain that, sir? Like,
I don't know. I think it's very difficult. I can't, because the biopsy was also done late. We don't know. And previous biopsies also, I think you have to review all the previous biopsies and see what it actually was. Now, the first biopsy, it said, was showing TMA with some deposits. No, it had IgA and
IgA, yes, sir.
Something was
looked
there.
More like a IgA, sir.
Yeah. Second biopsy did not show any TMA.
Yes, sir.
If I remember. So first biopsy, the TMA may have been due to the accelerated hypertension also. So you must remember that accelerated hypertension, so-called TMA, malignant hypertension changes, 30% of them will have genetic abnormalities in the complement pathway. So primary TMA is like that. So 30%, that's the general. So we have to do a genetic study in them also. The importance is that if you're doing a genetic study, then you treat them with eculizumab. Many of them improve also if they have a genetic. So this could have been a primary, but why the second biopsy did not show TMA? If it was a primary TMA, that should have been there in the second biopsy also.
Yes, second biopsy, yes.
Sachin,
the biopsy was reported at different places, sir.
The second biopsy, did it have vessels in it?
Yes, ma'am. Whether hypertension changes were there, but TMA changes were not there, ma'am.
Is it arteriosclerosis was there in the biopsy?
Tiredness, onion skin changes not there. Okay.
No, onion skin was not there. That is just arteriosclerosis. That's all. So my point is that probably if you look at the whole picture and you want a unified diagnosis, I would think that's probably one of the C3GN type of things. So like you say, immune complex mediated MPGN, C3GN, these may not be primarily genetic. Only about 20% of them are genetic. Most of them are antibody mediated, C3 nephritic factors and others, which nobody's doing. And the tests to do C3 nephritic factors are very ridiculously complex also. And those things, even though it's C3 nephritic, it doesn't respond to immunosuppression very well. Even though they are autoantibodies, even rituximab, nothing treats them properly. So that could be cause of the recurrence. So one thing we can do is look for any C3 NEFs, but I don't know anybody's doing that. Are you doing that in Vellore?
No, we don't do nephritic factors. I think Lalpath does C3 nephritic, but not the entire complement functional assays.
Yeah, they're not doing that. Nephritic factors, I don't know anybody's doing that. I think
C3NF, they are doing in KM, sir.
KM.
Bombay.
You can
Yes,
try. You can try getting it done with
no, I did it for this patient, sir. It was negative, sir.
Because the C3 NEF, C4 NEF, C5 NEF, all are there. Look at about 60% of patients will be due to C3 to nephritic factors. Of them, if you look at this will be 40%, 40%, 30%, something like that for C3, C4, and C5. And they're overlap. Some will have both. That's why you have more than 100% in that group. Some may have C3 and C4. So if you're looking at C3 alone, it may not be. You have to look for C4 NEF and C5 NEF also. Now, unfortunately, all these the original tests are done by agglutination of sheep erythrocytes, which is a very difficult process. So to standardize these tests also is very difficult.
That is nice. Sachin, you raised a hand. Please go ahead.
Yeah. So question is more to you, I guess, sir, our nephrosurgeon. So he mentioned different ischemia times for upper, middle, and lower pole. So is it a common practice to release clamps pole by pole, like as you finish anastomosis and release the clamp?
Oh, you say you're asking sequentially releasing the clamp.
Yeah. No, the case Anand presented, he mentioned different ischemia times for upper pole, middle pole, and lower pole. That indirectly means the venous clamp is released, as well as upper pole anastomosis done, clamp release. Middle pole anastomosis done, clamp released. So our surgeons don't have this practice. That's
you're asking very apt, very relevant question today. So he said he anastomosed the main artery to the internal iliac and the small artery to the external iliac. Probably the routine practice, what we do, if you have two arteries, and the major hilar artery will be anastomosed to the internal iliac, then we release a clamp. And the two ways it will give you significance. One is how much the polar artery is having non-blanching. So how much it is really significantly contributing to the entire circulation, right? And though it is an end artery, sometimes the major artery will cover the 99%. Then we'll not mess up with the small artery, some become bleeding, other things and all. But if it is showing lower polar, it's probably supplying the ureter, then we do anastomosis, the second one. But the question here is, I think that will not make any sense because we are doing cadaver transplant after 10 hours, 12 hours of cold ischemia, and nothing's going to happen. But thing is, when the anastomosis time is extended, you can pour some ice water, cold saline, which that we can prolong. But generally, what we do, we release the first clamp. Then we'll go because the two arteries, one artery we are anastomosed with the internal iliac, the another with the internal external iliac. So that's what Sachin. Have I answered?
No. So you release the clamp, you checked whether it is blanching the entire kidney or not.
Yeah, exactly.
For example, if you have to anastomose that polar artery, would you put the clamp on the main branch again, or you will keep it open?
Now that's another thing. It all depends on how much backflow is coming. Mostly it's a venous-like blood will come. What we'll do, we'll put a very non-occluding, very small 1 pound pressure, very small bulldog clamp. And we'll intermittently release and reclamp it, because otherwise it will interfere with anastomosis, right? Okay.
Right. Yeah, that's what. Because if there is a bleeding from venous side, then the surgeon will get disturbed to handle that venous bleeding instead of completing the anastomosis. Yeah.
Beautiful question you asked. This is what is happening inside the theater all the time. So when we take 3 stitches, we'll release the clamp, then flush it, then again apply clamp. So it will take some time, but this is what the patients require. Some kind of thing is.
Just before we close, can we ask Dr. Swarnalatha if she's there to comment on those biopsies also?
Okay. Very interesting cases. TMA in IgA nephropathy, that's been our experience, is not uncommon. In fact, the literature says that it occurs in 5 to 50% of IgAN and is independently a risk factor for progression to ESRD. So my own feeling on that, I think it was the case too with IgA, that it is an IgA nephropathy with a TMA. And we have seen 2 cases, but I haven't been able to follow up, where the recurrent disease was TMA in those patients. So I think we need to be aware of TMA as a part of IgA nephropathy. If you look carefully enough, you will see it in a significant number of IgA nephropathies. And I think my own feeling is that they do recur after transplant as TMAs. I mean, this is, I don't have enough literature to back it, but I think that's my thing. And so I think there was obviously it has to be the same disease. So something with the IF and C1q again in IgA, you can get a little bit in IgA sometimes, and that does not make it lupus. You need to have the serology to call it lupus. So I don't think it was a case of lupus nephritis. Yeah.
Thank you, ma'am. Thank you. So that makes we are coming to a conclusion point. Thanks, Pani and Anand. And I should appreciate Anand, but for where all the presentation was very candid. And, so you don't, you know very well this is great. It will evince a lot of questions from many people, experts like Satya sir and ma'am. So despite that, I think you presented in a very, very candid way. I think that this is a big topic. And you proved a lot of things actually. The de novo is a very easy to diagnose or difficult to diagnose, but easy to manage. But recurrence is easy to diagnose, but difficult to manage. You made that point very clearly. Very nice.
Yeah.
And we enjoyed your presentation because it's all in sequence. And though you lost 2 patients, graft you lost, and the third one is a real eye opener. Multiple arteries. One has to keep in mind raising LDH with. One has to go for further investigation, not doing the trend every day, getting confused. One thing is do a CT and find whether it is ischemic graft is there or not. That's the one way. And you made a very flashing second. You made a point. You didn't do anything because the graft is functioning well. So this is a common sense approach. Whatever the report shows, something when the graft is doing well, patient is fine, and think let us watch and wait and watch. That's how you made it nicely. And coming to Pani, when the Pani is extensive, it's a nice review of the entire IgA nephropathy, and you said IgA nephropathy is a systemic immune complex disease with the renal involvement as a predominant. And Sachin asked one question about despite immunosuppression is progress. The unfortunate thing is though there is a lot of immunosuppressants available, it neither it prevents progression nor it prevents a recurrence. So it's a funny disease, and we are all getting cluttered with ideas, and throughout the world, and many drugs are coming up. Still, we are in a ocean of confusion. We are just traveling. So that's right. And you made the cause of entire process in a post-transplant, post-kidney liver transplant could be pre-existing IgA or GDA, IgG1, gut-driven, or something like incomplete clearance. And you said about bone marrow blah. And you raised one question about the research part of view that nobody's thought about GD, IgA antibody complex. That's the one question that evoked a lot of interest in our mind. And you left a lot of point to be carried home as a message, and because the discussion was good. And finally, panelists added real glamour to this meeting, and I think they've rated a very important point, genetic test. Until otherwise, you call it as there's no such thing called in second in transplant. You think every patient is a primary, until otherwise, you delay. Refute with some kind of investigation. So that's what Balan sir and ma'am rated a very nice point that genetic. And Balan sir raised a point about MLPA, the test, the copy number variation to be because sometimes whole genome might miss. So he made a right point about that. And the another point, really the good carry message, all the malignant hypertension causing TMA, that is TMA mimics 30% of genetic influence. That's a real nice point. So I think the overall point is we should be more cautious, because in India, one graft is one life, and if they fail, they take it as a option choice of life is end, and that's all. So I think we have to have a meticulous approach to our patients. So once you do a as patient transplant, it fails, then it become patient perennially, then lifelong they'll become sensitized. So let us not delve into, force ourselves into a quick conclusion that let's go for transplant. So detailed investigation, genetic workup, and all the information you provided, both of you, I think it is a very nice points we carry home forward. Thanks once again. I think this meeting gives a lot of interest to many. It is generating a lot of interest in many people. We are looking for a platform where 4,000, 5,000 people are coming under one roof. Because right now the WhatsApp has got a limitation. I'm working seriously on that issue. Probably by mid of this year, the entire nephrology will be under one group for the academic pursuit. So thanks, and the panelists and the speakers, and ma'am, Sonalata ma'am, you added very few points. You hit nail on the head by saying that some of your points regarding IgA could be the first possibility with the TMA. Maybe that's the chance. Every collateral thinking gives some idea in our clinical practice. So this is what we make, it makes a difference in our approach towards the patient. Thanks, Anand and Pani, Balan sir, and Swarnada ma'am, and Susina Alexander ma'am. Thank you. Good night.
Thank you. Good night.
Thank you.
Good night.
Thank you.
Thank you.